and I think it's not the first time for most of you, no?
Yeah.
Did you come for the AIO? No?
Yes.
Course?
Yes.
Who came? Yes, I remember it. Okay, so I know that your level is very high, and I will try to be a good professor for you this afternoon. I know that I have Dr. Riyad Moussali that can help me for some translation. If you see that when I speak it's not enough comprehensible, just feel free to stop and to tell to Riyad to explain in Arabic. Yeah. I speak Arabic from Morocco. I am from Morocco, but it's not the same than yours. So I'm sorry, but I speak very well Arabic. Okay. I'm born in Meknes. Do you know Meknes in Morocco?
Yes.
Yes.
Yes. All my family and I'm born in Morocco. So we'll speak today about. First of all, I know that you know a lot of things about bone graft. I know that here there is many maxillofacial surgeons. No, who is maxillofacial? Okay. So it's not the same level, it's not the same kind of work you do, but I will try to give some evidence-based. I like every time it's necessary, you know, to go in some evidence-based. You know some things, you don't know others, but it's necessary, I think. And after we'll go to the clinical. Don't worry, I have a lot of things to show you, and we can speak, and you can stop me to discuss with some case that you have in your office. If I don't finish, I don't finish, no problem. Just feel free to speak with me, because you're here once. From how long you are not here? You don't come here. You didn't
3
come.
years. For me, 3 years ago.
3 years. So, okay, so we have things to say. Okay, so first of all, the extraction site. Some evidence based. Okay, when I take out a root from an extraction site, now why I want to speak about that? It's because in my office now, I'm very concerned by that. Why? I understood. Sorry for my English; it's not so good, but I do my best. You know, even if in New York University, I always do my best, and they love the joke, but it's okay. Why it concerned me? Because if you take care of the blood in your root, okay, in the hole that you let, you will have bone. If you don't take care of the existence of this blood clot, okay, it will be an adventure. You will see after 3 months. But now I know that if I don't explain to my patient how to let the blood clot inside, you know, if he comes at the house, he does a wash mouth and he let the blood clot out of the mouth, it's finished. After you have a hole, and after what is the gingiva, the epithelium, how the epithelium will close your extraction site. Tell me, how do you think is the epithelium vascularized? Do you think the epithelium is vascularized or not? Tell me. You think yes? Who think yes, the epithelium is vascularized? Is the tissue vascularized? Who think? Tell me. Okay. I can tell you that it's not vascularized. So when the epithelium needs to go and close the extraction site, he needs some support with vascularization to go and to grow. You understand? It's impossible for this tissue to grow without some blood supply. So if your blood clot is here, okay, you have some stem cells inside, you have a lot of things, you have some, after maybe 3 days, you have some new vessels inside, and your gum, your epithelium will grow and will close. Okay? We know that we close around 1 millimeter by week. So, if, for example, you want to go back to this site to do a surgery, maybe, and you want the closure will be finished. You see that you have, for example, 1 centimeter of hole. Okay, so you know that you have, it will grow 1 millimeter by week. So you say, Miss, we will schedule your surgery in 6 weeks. Okay, let 1 week like that for security. So that like that you can think. But if you see the blood clot went out or there's no blood clot, it will not be the same thing. You will need, the epithelium will have to go all along the walls to find, okay? And you will see after, it's not so easy. And when he will find some blood clot, he will close. So you will have a hole after a few weeks, and it will necessary more time to close your centimeter of hole, okay, of extraction site. And sometimes when you see from the mouth, for you it's like it's not closed, but it's closed, but it's closed down. Okay, so you have also to think about all these small details. Now we are not in the time of the implantology when we do a big hole implant, blah, blah, blah. We have to think about biology. We have to think how we can schedule some good surgeries and other to let more time. If you think your patient, so for example, the laser, you have a function, I don't know this one, but I have another one. You have a function that you can give some small impacts inside the bone to maybe, for example, the blood flow too much. Okay? So you need to stop it and so you have some functions with a small power, and you take some impacts on the bone and on the blood, and it will comment on dit ça gélifie. Gélifie, comme un gel, like a gel. You know, it closes and it stops the blood clot like a small gel. And like that, I know I can stop. I look at the clot. I say to my patient, don't do wash mouth at home because it's important for more than 48 hours. If at the other side, when you go to the house, take some ice in the mouth, like that you have some constriction of the vessels. All that thing, all the advice you can give to your patient for you to be better in few weeks or months, it's so important for the aesthetic, for all those cases. So that's the reason why I speak about the steps of the healing of an extraction site. So, stabilization of the blood clot, formation of a provisory matrix after 7 days. So you have after the woven bone, a lamellar bone. Okay, the difference between this one, okay, it's not a hard bone, and the parallelism of the collagen fibers is not good, and in the lamellar bone is more organized. Okay, in Haber system, you know the Haber systems. Okay, it's parallelized, and so it takes a long time to have lamellar bone. But we can work on this bone after a few months. So, and we need, it takes more than 6 months to have the bone marrow inside. Those are all the steps that we need to think and to know. Okay, here Araujo in 2005, he showed us that the buccal bone will resorb, you know, like that. So we have the step of the blood clot here, the woven bone. The woven bone will mineralize little, and you see that the buccal bone goes down, resorb, and the buccal bone here finish here. It's a lot of resorption. It's average of 3 millimeter. But you know, also I will speak you in this course about studies. And in the studies, every time they give you an average. You know, they say to you, when you put two implants close to each other, you have 2 millimeter of bone resorption. I don't know. And what you have to think always is that in the study the average is right, but it's an average. And in your clinic you will see all the cases. You will see 0 resorption, you will see 5 millimeter resorption. It's impossible for all the patients to be in 3 millimeter or 2 like the average. Okay, it's an average. So you have to think that some patients don't have any resorption. You don't understand why. Others a lot, and so, a few, la plupart on dit. Most of them. Tu vois, des fois je bloque sur des mots comme ça, je reste calé. Sorry. Sometimes I think about one word and I don't find it. Okay. So we have a loss of 25% of the volume of the extraction socket, okay, the first year following the extraction. And most of the volume that will go down is 55 in the buccal ridge, okay, for 2 to 4. You know, 2 to 4 is like I say to you, not sometimes 0, sometimes 5, but 2 to 4 you will find a lot of them. Okay, disappear in the first year. Okay, so that's the result. 2/3 of the resorption takes place within 3 months. So it's important also, if you know all the steps, you can schedule and explain that to your patient for him to accept soon, quick, the treatment plan. He has, you know, sometimes I sit with the patient, I explain him some biological things like that. Because sometimes he said, okay, I have time, maybe next year I will make money during the year, I will make some economy and to pay that. But if you see a patient with a thin biotype, gingival thin biotype, not a lot of bone in the buccal part, it's an aesthetic zone incisive. Wow, you think you know that you will have problem in few months if you don't. If the patient doesn't accept to do in 3 months or in the few days after the surgery all he has to do, you know that you will lose a lot, because the patient and his biology, it's like a thin, everything in thin, not vascularized, and everything will go down. And some others, biotype gingival very thick, and everything is here. So you can let some time, and maybe this patient is not very concerned by the aesthetic, so it's not his problem. He wants just a tooth for the sandwich, you know, and that's it. So you have to take all these parameters. Okay, so you have also, you know, some bone just inside the alveoli, the socket. That name is the bundle bone. Is the part of the bone where the fibers of the periodontal ligament, okay, are in contact with the root. This bundle bone is lost in all cases after a tooth extraction. So that can make also a delay for the gum to close, because when you take out the tooth from the socket, the resorption of the bundle bone starts. Okay, and when you have a resorption, you have all inflammatory steps for the resorption. So it's not easy for the gum to go and to grow inside this environment. So you have to think also about that the bundle bone is always lost in all the cases after extraction. So what we can do, we can fill the socket with like a socket graft technique. So you take out your tooth, you put some biomaterial, okay, But what you have to know is that the resorption of the vestibular cortical will occur, but a filling of the cells helps to maintain bone volume, so it can be necessary, and the volume regenerated compensates the inevitable resorption. So some studies, but you know that in the study sometimes here is BioOS that paid the study, so they will say what they want to say.
Yes.
Okay, we can demonstrate a lot of things with the studies. It's very difficult. Now I have a good experience in the scientific world of the studies, and I can understand and I can see what are the studies manipulated, you know, and those that are good. Okay, so this is the classical buccal bone resorption. We thought in a time that when we put an implant in an extraction site, we thought that we won't have the resorption of the bone, but it still happened. Okay, you see that even if you put in the same day implant in the site of the extraction, you will have a resorption. And this is the example of geistlich bios, of a filling after the extraction, and we see that here the result is better for a new crest, you know, for a new ridge to be implanted. And what you have to know also is that here it would take more time to be ready for implant placement than here. I will explain that to you. You have also to know how it works to let the time necessary to do some step and to do another step. I will explain to you. You will understand. So this is, you know now that sometimes this small and thin buccal bone, we don't see it sometimes in the scanner, in the CT scan, we don't see it. We think there's no. There is one, but it's so thin that we don't see it. Okay, here we have a big hole here of resorption due to the infection. This is a result of the healing of a gum when the buccal bone was destroyed in the time of the extraction. So you know, if you are concerned by the aesthetic, if you are a patient and you see that when you sometimes the dentist, I see them that they take out the tooth, and after they don't take a probe to touch inside. Okay, they take out, okay, bye-bye. They don't know if there is buccal bone. Sorry. They don't know if there's still buccal bone or not. They don't know, they just take out and okay, bye-bye, patient, other patient, and so when you don't see that, this is the result after a few months. Go to do what you have to do to have a good result. When you have a patient, okay, it's very difficult to manage it and to handle those kind of cases. Another kind of resorption, another kind of healing. Okay, this is a young woman. Every dentist tried something on her. You know, everyone, he goes from the faculty, he looked we take a canine include that we put in here. They try everything on her, you know, and she came like that. You know, the hole, I don't know if you see, but the hole was very, very high. So what to do now? You know that you have a lot, not one graft. For this, you need many grafts. Why? I know, just like that. I see the picture and I know that I will need more than one graft, one bone graft. Why? Because I know that it's impossible for this gum, okay, to close a big part of a new bone. So I just have to do one small graft.
One by one.
One by one, and sometimes I have to graft some conjonctive, comment on appelle la conjonctive, non, soft tissue graft, mais connective tissue
graft from the palate. Okay.
Welcome.
Because we don't have a
We have to
gingiva.
grab some connective tissue. We have to do 1, 2. It took me so many time to finish this case. It was incredible. So, so this is a harvest system, you know, as we said. So this I found an experience and a study from 1983. And it's a long time ago, so we know a lot of information since a long time, and we never see and we never understand. You know, we had a long time in implantology just doing surgery, opening, and post-extraction, implantation, and I saw that. What is this study? It's a study. He did some small defects in the bone, and he saw if the healing was good. So when he did a defect of 0.2 millimeter of diameter, he said that we have a natural and perfect new osteon growth. Okay? It's a perfect healing, 0.2. When you have a defect of 0.5 millimeter, you need a help of another vessel. You know, so a vessel from here will grow an osteon for 0.2 millimeter, and you need the help of another one that is close to this one to do 0.2. You will have a good healing, but you need to have two vessels close to each other to do that. And when you go, so this natural healing is named osteogenic jumping distance. That's the name, osteogenic jumping distance. And when the distance of the defect is around 1 millimeter, it's not a very big defect, 1 millimeter, you won't have never a natural healing of the bone, 1 millimeter. So, what is the goal of the guided bone regeneration? Okay, it follows the principles of the guided tissue regeneration. Okay, and it's a surgical technique that selectively, because we want to select some cells, that bone cells, stimulate cell repopulation in a defined space. That is a very simple definition of the guided bone regeneration. Okay, so 1957, Murray was the first to do that. That is the story. He put isolating a plastic cage, creating a bone defect in a dog, in a hip. Okay, after healing, the interior of the cage has been filled by a newly formed bone. So that was the first. After Dalin, 1989, showed that it was also possible to regenerate bone around implants with a EPTFE membrane. I know that everybody knows, okay, EPTFE, okay? So, the goal of the guided bone regeneration is, firstly, to maintain the space for the bone regeneration. So, when we have when we have a defect, okay, to rebuild, we have to maintain the space of that we want to rebuild. That is the first goal. Second goal, protection of the blood clot, source of the bone regeneration. I say to you in the beginning of the course that we need blood, because in the blood there is some stem cells that will move into new body cells, and we want here that the blood clot will go to be a new bone. This space will favor the angiogenesis. So, okay, I have my defect, I have my clot. So in the clot, I need some vessels that go through the clot to give all the new cells to help the stem cells to go into new bone. And we have to place a barrier against cell invasion. Okay. Why? Because if my gum touch the clot, my gum will give some vessels into the clot, and the clot will understand that he needs for the stem cells to be gum. Okay. So if if we want the blood will go to be bone, we need just to let him and to protect him from others' tissues. Primary closure is very important. So you have always to look at the mouth, to look at the frames, to look at the insertion of the muscles, to see how the patient speaks, to see how the patient's laugh is laughing, to see how he does, because it's very important to see that, to be able to understand how to manage your gum. So this is the first step. We have a thin ridge. We open the gum. We put the biomaterial. So this biomaterial have to trap the blood here, to have our blood clot. We put the membrane on to protect from the competition of the gum. We have a primary closure that have to be maintained, and after that, the future steps will be that we need some vessels to go through the biomaterial, and day after day we'll have a transformation of the blood, the stem cells in the new bone, and you will have or not some resorption of your biomaterial, and like that you regenerate some bone. You have a lot of studies about bone regeneration. We know that it works very well. And this man in this study, I like this study because he worked about a lot of cases. He tried to put just a blood clot without membrane. He tried to let just the site like that to see if it will have some new bone. He put biomaterial without membrane, membrane without biomaterial, and biomaterial with membrane. All the cases he did. And what he said in this study is that when you have just biomaterial, sometimes you have bone, sometimes you won't have bone. If you put just the membrane with the blood clot without biomaterial, sometimes you have bone, sometimes no. And if you want to be sure to have both, you need, the ideal thing is a combination between a biomaterial and a membrane for the guided bone regeneration. So if you want to be safe for your patient, maybe you can just put one and not the other. But what is the price of this and this? Put the both and you will be safe for your patient. Okay, this is a case. Okay, we see it's a 18 years old girl, and you will see this case in the future of the lecture. You will understand something. So firstly, I put here some allogenic bone, so it's a human bone origin. We have the membrane on the biomaterial, and I have here the primary closure. What I did here, I took the gum, the free gingival gum, and I took it to close. I had, because it was an extraction, it was the day of the extraction. So, yes, I need, so what I did, this keratinized tissue is at the end of the surgery, at the occlusal part, not on the right side for the aesthetic. Okay? So that was more than 10 years ago. But it was the first time we were really just concerned to do bone. We never thought about aesthetic and just bone, bone, bone. Okay, we did bone. So this is the healing. And this is, you see here, we see the new bone. You see here, You recognize the new one? Okay. This is the bone. We have more than in the past, you know. We have a lot of bone here, and it's a real bone. We see blood inside. It's living. This is the first case. This is another one. It's also 18 years old man, and the dentist sent it to me because he saw in the panoramic a big bone loss here around those two teeth. So we did a CT scan, and what we saw in the canine, we had the beginning of the bone loss of the infection. In the lateral incisive, we see here no cortical bone and no bone in the palatal cortical. Here in the central incisive, no bone here in the nasal floor, no bone vestibular, no bone palatal. So we took out the two incisors, and I asked the dentist to do root canal treatment. So I cut the canine. Here I put this piece to show you that we had a very big hole, and we had here the mucosa of the nasal, of the nose. Okay, we put some biomaterial. At this step, you really have to see if your biomaterial becomes red. If it doesn't become red, you will never have any bone. You can wait 5 years.
Before we put the
Yes.
membrane, we must see the red.
Yes.
The blood.
If, think about this, no blood,
There is
no
no
bone.
No blood.
Don't, okay, you can use the best biomaterial you have. No blood, no bone.
Even
Just
for implant.
give
No
those
blood,
kind
no
of
life.
things in your head.
Yeah.
It will work. If you don't find, if you see it's not red, there's a problem of you have to take out your biomaterial, okay, in a cup, and you have to push some to grind
until
bone
you
to see how to have blood.
Yeah.
Really, it's very, and I will explain to you why and what you have to do. You will see a lot of things. So here you see that everything here is red. Okay. I closed, as in the beginning of the course, I did my best. I closed, I cut some fibers, and I closed. And now I know, and we all know that it's a mistake here. We have to do differently. But it's necessary to see how we did in the past and how we have to do now. This is the closure. Very nice bone regeneration. Very nice also here. You see the canine, you see the two incisors. So at this step we have maybe 40 to 4 months after. Maybe we have 40% of newly formed bone and 40% of the biomaterial that stay in the site. This is the step of the surgery for the implant placement. Here we have new bone. We put 2 implants with switching platform. It was the first time we had that. This is the beginning. We took a small harvesting of bone to see what kind of bone we have, to understand, because 10 years ago we weren't so sure that it was a new real bone, you know. So we had to do some proof to be sure of that. So it was an allogenic bone, you know, and we saw in the histology that all around the allogenic bone, here we have some lacunae for osteocytes that were empty, and when the bone is living and it's a new bone, we have the osteocytes that are inside the lacunae. You see? So that you can understand this is a live bone, and this is a dead bone, biomaterial. Okay, that is in histology how we see that. So after that, I did a surgery to take my gum and to put some keratinized gum here. You know, you see, it's not very nice, but I did my best. And the dentist, he did the 2 crowns. This is the result 10 years ago. So I saw this man a few months ago, and it was very nice for me to see him. The crowns were here, the implants were here, and I did a CT scan, and have a look. This is how it's now. This was the day of the implant placement. You see, it's very interesting. We don't see a lot of cases 10 years after. So now, what we can understand when we see that? Firstly, it seems to have some, you recognize here the switching platform? You know, all of you know. But, and we see that there's no more biomaterial inside. It's just the bone of the patient. And we have a lot of study now that show that the guided bone that we regenerated, it's a new bone that can really work for many years, excuse me. So because we can be afraid and say how long this bone will still be in place, it will resorb or not, like the autogenous bone did. We have a lot of questions, and it's necessary to give some answers to that. Indication of guided bone regeneration technique. There's a lot. In every cases you need bone, and you don't, and where you don't have enough bone to do your clinical case. I'm sorry, you need? No? You want? It was good. Zoro. Okay. The biomaterials. So we have autogenous bone, allogenic bone, xenograft, and synthetics. In your country, which one you don't have? You have all of those? Do you have
Allogenic.
So autogenous, sure. Allogenic. Yes, you have.
Allogenic.
Xenograft, you have also.
Yeah, using
okay,
xenograft
so you
more.
have experience
And
with all the
xenograft and
biomaterials. Very nice.
synthetic more.
Because there are some country they don't authorize some allogenic bone or
No.
so. That's the reason why I asked the questions. Okay, we start with the gold standard, that is the autogenous bone. So you know the harvesting we put with a screw, okay, and this is the site few months after, generally 6 to 9 months. With autogenous we have to wait, okay. So you see that we have some small resorption. Sometimes there's a big resorption, sometimes no. It depends from where you took the harvesting bone, and sometimes effectively you don't have a good stabilization of the bone during the years. So it's very difficult with the autogenous bone to know how it will become few years after. They say that we have an average of 20% of resorption, but I say to you in the beginning, average, it's an average. Sometimes you have 50%, sometimes no.
And you can't control.
No. That's the problem. The problem is when you put a new bone, okay. So you take a bone from a site, okay. It's a dead bone. You took out from the body, dead. Okay. You put in on a new site. You screw it, and you pray for the vessels of the reception site that gives vessels inside the bone, okay, and that it will help those new cells, the cells of the autogenous bone, to live. But all the cells that are far from the beginning of the starter of the vessels, it will take time for that to go so far. So the more you add, the more you have to wait for the vessels to go there. So during this time, what you have, the cells will die. So it's some people have a very avec des vacuoles, un os très trabéculeux, trabecular bone, very big trabecular. So the vessels find way to go quick. Some people have a small trabecular, so